Assalamu alaikum. Thank you very much. Enjoyed your presentation there. Very simple question for me, but maybe very difficult too. Would any of this happened if we hadn't have had COVID?
Dr. Saha, we can't hear you for some reason.
Can you hear me now?
Yes, we can, yes.
Yeah, good afternoon, everyone. Alaykum assalam and Eid Mubarak for all those celebrating Eid. I'll be very honest. This wouldn't have happened if we weren't hit by the pandemic. As they say that always invention is the mother of necessity. Necessity is the mother of invention.
Inshallah. Thank you very much. Shukran.
Bill?
Yeah, thank you. I'm aware that with coding, particularly using ICD-10, the initial ICD-10 code will often change as a diagnosis occurs or as multiple diagnoses occurs, people move through a system. Are you essentially an ambulance service, and so you're looking at the initial ICD-10 code you encounter?
Yeah. So as you're aware that the coding guidelines for COVID has changed from the time the pandemic has started. So we used to always, so we used to look at the first encounter within the past 14 days. And then later on, the guideline has changed to include encounters within the last 2 months. And if the patient doesn't have a 2 negative for the last 2 months, then he would be coded as positive till he gets 2 negatives. And this is what we used to always track during our automation. So the challenge was that the report, it's not only about auto-coding. There was lots of analytics and data mining that used to happen because the guideline mandates the code to be linked to the result. So it's not just about extracting all the COVID encounters and assigning a code to it. We used to go into the results, and the result could be either negative or positive or inconclusive. Anything would be then reported and linked. It should have also some historical background check to ensure that the patient had 2 negatives within the past 2 months. And this was the challenge. In addition, to make sure that these claims were submitted within the timeline submission, because the payers today have got a specific time for submitting the claims. And if you missed this deadline, it would end up in denial. So we had the challenge of submitting all these bulks within an estimated timeline, with no additional manpower. What we could assign is 3 FTEs just for the extraction of the report, for the data mining, and for the submission of the claims through Cerner. And by doing this, we have saved an additional manpower of 65 coders. Our team today is around 62 coders, and they were totally utilized to code our encounters of medical outpatient encounters that continued during pandemic. Because the ambulatory healthcare services continued 2 lines of medical services, COVID and non-COVID. So even with the pandemic, we did not stop our non-COVID services. We had to still go and code our outpatient encounters, our preventive screenings. So, and at the same time, we didn't have budget for additional manpower. And the spike of COVID encounters was increasing day by day. At time, as mentioned in the video, our coder needs to code around 400 claims per day. In 2021, this has spiked to 16,000 encounter per day per coder. And at times when the COVID trend has really increased, this was maximized to 26,000 encounter per day. So we didn't have any other solution other than to go into scripting and then putting those logics, implementing the logics of the coding guidelines together with the regulatory and the clinical guidelines, which change from time to time. Because if you're aware, we had protocols for screening patients in UAE. So we had some patients who are screened based on their self-pay, and they used to pay for that. And we had patients who will be screened, and this will be funded by the payers. This was also another part of analytics that we had to do when we do the scripting, so that we identify that each category is being today forwarded to the right fund for payment within the timeline.
So what I don't really understand is how you can auto-code everyone you encounter unless you have their vaccination history and medical history available to you in databases. Do you have that data available?
Yes. So in Cerner, Yeah, in Cerner, we have the report that will show you the result, and will show the historical results of the different PCRs. And today we know that a PCR has got a CPT code for that PCR as a test. So we used to extract the report, yeah, and we used to do some historical checks, and based on that, we used to assign the codes.
So you're taking all these data points and you're using the logic between them to assign the codes, because yeah, I get it now.
Yeah,
Thank
exactly.
you.
So it
That's
was
clear.
like a combination of multiple reports that's been utilized and merged together to come up with the final output.
Thank you.
Welcome.
Okay. Any more questions, please, jury? Yunhua?
Maybe, yeah. Okay, still on the area of risk mitigation. I presume accuracy is important, especially in healthcare. I mean, you talk about this auto coding. Is it right now 100% automated, or will there still be a need for human to kind of do some checks? How do you mitigate the risk of inaccuracy?
Yeah, that's a good question. So we divide our volumes into two types of claims. Claims that today have got clear results, and that's coded accurately. We have certain checks, which I'll come back to that later. And we have today encounters which have some sort of documentation from a physician. So whenever an encounter is having some sort of documentation from a physician or a nurse, this has been excluded from the file, because that would need a manual review by a coder. Today, we understand that, especially for COVID-19, these reports were accurately reported regularly to the regulator. So they had to be 100% accurate. We had multiple checks through the process for tracking and accuracy. So the first testing would be done daily by the team to make sure that there's no any system glitch. Because today we know, as any system, there could be glitches, there could be the script could run duplicate dual coding can happen. So this was a daily check. Another set of check would be post submitting it to the payer, and getting back our remittance advices from the payer would find that it's clear with less denials. This has also been proven. And the third check is through the Tasnif. Tasnif today in UAE is one of the third TPA companies for auditing our clinical documentation. And while auditing our claims, they have scored us as A. Which is above 96% in accuracy of clinical documentation. So by these three controlling steps, we ensure that it was a successful criteria somehow.
Okay. Abraham, have you got a question or not?
Yes, Robin, thank you for that. It's a quick question. I just wanted to know, is there any evidence of manpower resources being more efficiently utilized now? Because obviously, you did touch upon the staff satisfaction being higher. You'd have saved an X amount of manpower by implementing this. So what's the evidence of manpower resources being more efficiently utilized by the organization?
Yeah, so if I understood your question correctly, we're processing, before COVID, we're processing yearly around 2.5 million claims in a year, and with the help of around 62 coders in the team. This number has doubled during the pandemic because we are processing COVID and non-COVID. To be able to process these additional volumes within the submission timelines to get it paid accurately, we would have needed to recruit around 65 coders. And the recruitment wasn't easy, and we didn't have budget for that. And also, and I'm talking about the direct cost, but there's another indirect cost that would have been counted, because people during the pandemic used to work from home. So these were additional things that we would have been consider it as a challenge, but we saved all this by just going into scripting, and we saved like a manpower cost of additional 65 coders to manage these claims.